cardiologist. I'm here with Dr. Hitesh Patel, cardiologist. Good afternoon, Hitesh. How are you today?
Very good. Thank you, Patricia.
So our topic today is on calcium scoring and CTCA in asymptomatic patients.
Today, I've come prepared to discuss the role of coronary artery calcium scoring. The INTERHEART study was an international case control study that has given us a lot of information, including the observation that South Asians had their first ACS event 10 years before European people. The investigators also published an analysis that stated that 90% of the risk of myocardial infarction was accounted for by these risk factors and protective factors. In addition, they reported that a waist-hip ratio above the 86th centile in the study had an odds ratio of 2.09. Asians' ideal body mass index is 18 to 23.
I believe 26, 27 is the cutoff for actually obesity as opposed to 30 in European population.
The 4S study in 1994 informed us that for secondary prevention, treatment with simvastatin reduced absolute mortality by 4% after a mean follow-up of 5.4 years. The average total cholesterol was 6.7 millimoles per liter. If I recall correctly, with statins being quite expensive at the time, we could only get special authority for statins for secondary prevention if the total cholesterol was greater than 7 millimoles per liter. In 2003, statins were cheaper. The New Zealand Guidelines Group published these risk charts. The Guidelines Group included these ROC curves in their document. We could be evaluating a test and we plot our test value on the x-axis, and we have two populations. Our first population is healthy. When we measure the diagnostic test in the second population, we find there is overlap. We set our threshold value and we find that our sensitivity is not 100%. We also find that our specificity is not 100%. We could move our diagnostic threshold value to the left and to the right and get different sensitivity and specificity values, and we could plot this on a graph. So the ROC curve plots the sensitivity on the y-axis and 1 minus specificity on the x-axis. Curve C is the diagonal of a square and the area under the diagonal is 0.5. Curve B has an area under the curve of 0.85. Usually we might pick the diagnostic test threshold that gives us the best compromise between sensitivity and specificity, and this is around this mark on curve B. So let us go back to the ROC curves, and we find that in 2003 the 15% CVD risk threshold would have a sensitivity of just around 20% in women. Now, if this threshold had been set at 7.5%, then our sensitivity would have been close to 50% and the specificity would have dropped. This group that has a risk between 10% and 15% are what we now refer to as intermediate risk patients. Statins are cheaper and we can afford to treat more individuals that are at lower risk. But unfortunately, now statins also have bad press.
And that's not an easy thing to do. No. Patients are asymptomatic with intermediate risks to convince them to take a long-term medication.
The MESA study, amongst others, demonstrated clearly how the calcium score stratified individuals. The risk of events over 5 years was less than 1% in those with a nil calcium score. In the USA, I am told, many individuals have to pay full price for their drugs, so there's potential for loss of cost savings with use of calcium scoring. The analysis of the area under the curve was higher if coronary artery calcium score is included in the MESA study, that is, compared to risk factor assessment alone. This is an analysis of the intermediate risk group in MESA. The area under the curve of the ROC was actually quite low at 0.623, and there was a large jump in the area under the curve up to 0.784 when calcium scoring was taken into account.
Right, so there is a clear correlation between calcium score and future risk. What if the calcium score is 0? What does that mean?
This is a slide from one study that found that by 5 years, 25% of individuals with an initially nil calcium score had developed calcium. We know that some of the calcium values would have been quite low, but we also know some individuals can develop a relatively high score within a short time. We might think intuitively that the conventional risk factors increase our chance of developing calcium even if we start off with a 0 calcium score. And that is exactly what was found in this study. Some individuals, if we take the lifetime CVD risk into account, might still start statin therapy if the calcium score is low. For example, the diabetic population, or those individuals that continue to smoke and have at least one other risk factor. If it is decided not to start a statin in individuals with a number of risk factors, then you may have to repeat the calcium score in 5 years' time to know what your particular patient's trajectory is. There's no official screening program using calcium scoring, so it's not available as far as I know in any public hospital. Many guidelines now do recommend that you can consider using calcium scoring. So Southern Cross are not paying for it, as you know. When we accepted the rigid 15% CVD risk threshold for statin therapy, we only had 20% sensitivity for treating those at risk of CVD events in the next 5 years. To improve that sensitivity to 50%, we now have to consider treating a lot of the intermediate risk group. Coronary artery calcium scoring can be helpful in this group. A reassuring low coronary artery calcium score can change, and we need to keep this in mind. Next question might be, should we spend even more money and do a CT coronary angiogram instead of calcium scoring on our patients?